Trauma bays are loud, controlled chaos. Each second feels like it has a stopwatch ticking behind it. You get used to that rhythm. The clatter of the crash cart drawers slamming shut, the hiss of the oxygen tank, the flat commands from the attending, the muffled crying from a corner. Your brain learns to sort the noise from the urgency. It was a Sunday afternoon, mid-shift, late spring. EMS radio called in a pediatric trauma. 10-year-old male struck by a vehicle while riding his bike. Blunt force trauma, head laceration, suspected internal injuries. GCS score dropped en route. ETA was 4 minutes. That changes the tone immediately. Pediatric cases hit different. The whole unit adjusts. Re-prep trauma room 2. Standard setup. Monitor cables pre-plugged. Suction ready. Airway tray opened and checked. Fluids hanging and primed. We had respiratory and peds trauma team alerted. The attending was already in there by the time I snapped on my gloves. When EMS wheeled him in, his vitals were borderline. HR was high, BP low. They'd placed an oral airway and had given him a fluid bolus. His face was swollen on the left, clothes cut down the middle, road rash down his flank and legs. The medic called out injuries, timing, interventions. We transferred him from the stretcher to the bed on my count. There's a kind of autopilot that kicks in. Trauma nurses don't panic. We assess, head to toe, airway, breathing, circulation, neuro. A tech was placing a second IV as I got a BP reading and checked responsiveness. The kid started to move a little, eyes fluttering open. His pupils were reactive, though one was slightly sluggish. But what stuck with me was the look on his face, confused, like he wasn't waking up from unconsciousness, but waking up in a place that didn't make sense. He blinked at me, looked at his hands, then his chest, and that's when he said it. "That's not my body. Where's mine?" It wasn't panicked, just matter of fact, like someone trying to explain something that didn't match up. He tried to sit up, weakly, barely got his head up. Then his eyes rolled back and he went unresponsive again. We immediately checked vitals. No cardiac event. BP still low but stable. No seizure activity. We secured the airway, kept monitoring. The CT scan later showed a small subdural bleed and pulmonary contusions. Ortho confirmed a fractured femur. We admitted him to PICU under trauma watch. I didn't share what he said with the team. Not at first. It wasn't relevant medically. No protocol exists for identity confusion post-trauma, unless it presents as a psychiatric concern, and in trauma cases, neurosymptoms are interpreted through a physical lens. Glasgow Coma Scale, pupillary response, motor function. But it stuck with me. The clarity in his voice, the way he looked at his own hands, like they were foreign, as if the body he woke up in didn't match what he expected. That night, I went up to PICU before end of shift. He was stable, intubated but sedated. Mom was in the room, asleep in the recliner. I checked the log. No agitation, no further consciousness, no repeats of the phrase. The next day, I brought it up casually to one of our trauma docs, Dr. Franks, older guy, seen everything. He said it wasn't uncommon for trauma patients, especially kids, to experience disassociation. Body schema disruption, he called it. The brain protecting itself, disconnecting perception from the physical pain, especially in head trauma. He said it like a clinician, but I'd seen kids wake up scared, or combative, or crying. This was different. Weeks passed. I heard he'd made it through surgery, walking again, after rehab. No lasting neurodeficits. Good outcome. About a month later, I saw his chart during another shift. He'd been discharged. I don't usually get to see what happens to patients after they leave us, but this one lingered. There's nothing eerie about it. If you stick to the medical chart, subdural hematoma, tib fib fracture, 2 units of blood, standard treatment. But there's no chart for what he said. That's not my body. Where's mine? Could have been a dream fragment. Could have been a brief neurodissociation. Could have been a child waking up confused and scared, and trying to make sense of the pain. But for a second, just a second, it felt like something deeper. Like that boy's soul opened its eyes before his body did. Hello friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare. Room 8 is one of our lower acuity observation rooms. 2 walls, 1 chair, cardiac monitor, oxygen outlet, whiteboard with the date and nurse's name written in dry erase. We use it for stable patients who need labs, IV fluids, or monitoring, while we figure out whether they're safe to discharge or should be admitted. It was nearing the end of my shift. Around 6:10 a.m. nights in the ER can wear on you, not just physically but emotionally. You absorb people's pain, confusion, fear. You multitask through trauma alerts, strokes, overdoses, psych holds, and broken ankles, and somehow still find time to update charting, speak to worried families, and deal with pharmacy delays. That morning we'd had a full house. We'd just transferred a sepsis patient to ICU. I was catching up on med reconciliation notes when I got flagged. Unidentified male adult walk-in, found unresponsive outside a bus depot downtown. Brought in by EMS. No ID, no phone, no belongings. Awake and oriented, but confused. Trag had placed him in room 8. Vitals were stable, blood sugar normal. He wasn't combative, just quiet. Looked around a lot, kept asking where he was. They wanted me to initiate labs, monitor, and do a more thorough assessment. I grabbed a blanket, the portable scanner, and his chart on the way in. Pushed open the door to room 8, and just stopped. Sitting upright in the bed, gown loosely tied, blanket over his legs, was a man in his 70s. Thin frame, slightly hunched posture. Full head of white hair, neatly combed back. A faded birthmark over the left eyebrow. Clear, ice blue eyes, and a tired kind of calm in his expression, just like my grandfather. Not a resemblance, not a passing similarity, an exact match. My grandfather died in 2019. Heart failure. I'd held his hand during his last hours at the assisted living center. I remembered the way his skin looked, the way he smiled when he said my name one final time. There's no forgetting that face, but there it was again, sitting in room 8. For a moment, everything felt too still. My feet felt anchored. I wasn't afraid, just confused. The rational part of me kicked in. I double-checked the chart. Male, age estimated 72 to 75. Found unresponsive, but came to on scene. Alert and oriented to person, not time or place. GCS 15. I finally stepped forward. Sir, do you know your name? He looked at me, didn't answer, just smiled. I tried again, more gently. You were found outside the station. You're at County General. Do you know what city you're in? He looked down at his hands, then back up. They told me I was going home, he said. His voice, same cadence, same timbre as my grandfather. We aren't supposed to project. It clouds judgment. That's drilled into you in trauma training, psych rotation, grief processing courses. But I couldn't help it. I asked one of the techs to step in and do vitals while I stepped out to clear my head. I spoke to security and social work. There was no wallet, no wristband, nothing. The officers had already checked missing persons, contacted local law enforcement for prints. He wasn't in the system, not homeless, from what they could tell. Clean clothes, no needle marks. Nails were trimmed, skin clear, looked like he belonged somewhere, just not here. He stayed with us 36 hours. He'd eat, drink, answer a few yes, no questions, but he wouldn't or couldn't provide a name. No signs of head trauma. Labs were mostly normal. Connecticut showed mild age-related atrophy, but no acute changes. No alcohol, no drugs, just confusion and quiet. The morning of his second day, I went in again. He looked at me as I entered. This time his voice was stronger. You remind me of someone, he said. I almost laughed, but didn't. I replied, you remind me of someone too, and we left it at that. By the third day, the social worker located a long-term care facility 2 counties over that had reported a missing resident, an Army veteran named Thomas J., who had wandered off during transport from dialysis. The birthmark matched. Fingerprints matched. His family had been notified. Before he left, I helped load him into the transport van. He didn't say much, but as I buckled the gurney straps, he held my hand and said, "Tell your grandfather he raised you well." I didn't respond. I couldn't. I just nodded, shut the back doors, and watched the van pull away. The ER isn't built for closure. We stabilize, we treat, we refer. Most of the time, we never find out what happens after patients leave our care. That's the nature of it, acute medicine. Not long-term, not personal, but some cases stick. It was a slow Tuesday afternoon, which is rare. The board was light, no ambulances inbound. I had just finished up with a suture removal when triage called me about a walk-in older gentleman, possible dehydration. The note said general weakness, lightheaded, dry mucous membranes, borderline hypotension. He was assigned to room 5. I walked in to find a man in his late 70s, maybe early 80s, thin, well-dressed, button-down tucked into slacks, cardigan draped over his shoulders. His skin was pale, but his eyes were sharp. There was a stillness about him, like he moved at a different pace than the rest of the ER. He smiled the moment I entered. Didn't mean to take up a bed. Just felt a little off, he said. I did my assessment. BP was a little low, heart rate steady but soft. His skin turgor and mucosa suggested mild dehydration, likely from the heat. We'd had a sudden heat wave, and he'd mentioned spending most of the morning gardening. We started a liter of normal saline, ran routine labs, and hooked him up for telemetry just in case. Cardiac enzymes were negative. No chest pain, no shortness of breath. Vitals gradually normalized after the fluids. He joked while I was setting the monitor leads. It's always room 5, isn't it? 5th time in the ER this year. I think this room likes me. He wasn't confused, wasn't agitated. Cooperative, oriented, polite, and calm, too calm, in a way that almost felt rehearsed. The attending signed off, likely heat-related dehydration, no acute findings, safe for discharge with instructions. He was to follow up with his PCP within the week. A volunteer helped him gather his things. He thanked us each by name. As he walked out the double doors of the ER, he stopped, turned back slightly, and smiled, not in a playful way, but with a strange finality. "I'll be back tonight," he said. Not dramatic, not even strange on the surface. Sometimes patients make light of the revolving door of hospital visits, but there was something in his tone, like he wasn't joking, like he knew. I didn't think much of it. We had a shift change coming. Paperwork, handoffs. A trauma came in around 6:45 p.m., distracted us all. 2-car MVC. I didn't think about the old man again until I heard the code blue over the intercom at 12:13 a.m. Code blue, ambulance bay. Incoming, 78-year-old male. Cardiac arrest. They wheeled him into trauma room 1. EMS had been doing CPR for 6 minutes. Found him slumped in his car outside a gas station, engine running, foot on the brake, lights on. No identification at first, but I recognized the cardigan. Same man, room 5, same day. I took over compressions. His chest moved with each push. The monitor flatlined. We followed the ACLS protocol, EPI. Compressions, shock once, repeat. Still nothing. 10 minutes passed, then 15. We called it at 12:32 a.m. It was quiet after that. Just the usual silence that settles in after a failed resuscitation. I removed the leads, wiped his chest, and adjusted the sheet to cover him. His expression hadn't changed. Eyes closed, lips resting with the faintest suggestion of a smile. The same one he gave us at discharge. There was no sign of trauma, no sign of suffering. Massive cardiac event, most likely a fatal arrhythmia. Sudden, quick, probably painless. His ID was in his wallet. Name Leonard R., retired school principal. Lived alone, no listed allergies. Emergency contact was a niece who hadn't answered yet. We notified the medical examiner and started the documentation. Before I left that morning, I stood outside room 5, just looking. Nothing dramatic happened. No flickering light, no cold air, just the faint trace of antiseptic and printer paper in the air. Same as always, but I couldn't shake his words. "I'll be back tonight." Room 4 wasn't different in any official way. Same layout as the rest, 2-wall configuration, vitals monitor, oxygen, a bed that groaned a little when you lowered the head, and that cheap beige paint the hospital uses to make everything look sterile but tired. But we all noticed it, over time. You don't mention things like that in your first year. You're still trying to keep up with charting, with IV checks, with figuring out where they keep the extra lancets and how to make the glucometer stop error coding mid-shift. But once you settle in, once you've seen your share of codes and drips and death, You notice patterns. Room 4 always smelled like burning candles. It wasn't strong, not like someone lit a match or spilled wax. It was subtle, like a church an hour after mass. A lingering scent, not chemical, not antiseptic, not a smell you'd ever associate with bleach, betadine, or alcohol wipes. The first time I truly noticed it was during a night shift a couple years ago. I had a patient in room 4, middle-aged woman, possible TIA. She was stable, waiting on neuro to consult. As I stepped in to do a neuro check, I caught the scent. Low, smoky, not unpleasant, just unexpected. I checked the room, looked at the vents, the outlets, even pulled the curtain back to see if maybe something had been brought in by the last patient. Nothing. The trash had just been changed. The floors had been scrubbed that morning. No flowers, no perfume, and no candles. Obviously, we don't allow anything with a flame near oxygen ports. That's policy, reinforced every year during annual fire safety training. Still, the smell was there. That same week, one of the other nurses, Michelle, who's been there longer than me, brought it up during shift report. Room 4 again, she said, writing her initials on the board. And yeah, candle smells back. Another nurse, Eli, chimed in. It's always there. I think it's in the vents. Michelle just shook her head. Nope, not a vent smell. It smells like a vigil, like someone's praying for whoever's in the bed. That stopped me, because I knew what she meant. It wasn't scented. It wasn't industrial. It was spiritual, somehow. Something tied to memory or mourning. And I realized then, every code blue we'd lost in the last year, every one that hadn't made it through CPR or the crash cart, had been in room 4. I went back through incident logs during downtime, not official documentation, just mental notes, and a few sticky tabs from old shift reports, and it tracked. Unexpected code in room 4, sepsis case that crashed at change of shift. Room 4, sudden respiratory arrest in an elderly CHF patient. Room 4. Now we don't assign rooms based on superstition. ERs run on logistics, not feelings. If a bed's open, the patient gets it. That's it. But I started to feel it more and more. This subtle tension, whenever room 4 showed up on my assignment list. Nothing dramatic, just enough to slow your steps as you walked in. And the candle smell never faded. Facilities came in once, said they'd clean out the ducts, check for any residual smoke from past incidents. They found nothing, replaced a ceiling tile. Still nothing. The next shift, candle smell was back. It didn't happen every minute. Sometimes it was stronger during the night. Sometimes it was just faint enough to make you question if it was real. But every nurse who'd worked long enough on our team eventually acknowledged it. One patient, elderly, hypoxic but alert, mentioned it to me once. She looked at me as I helped her adjust her nasal cannula and said, "It smells like someone lit a candle for the dead." She passed the next morning. We never made it a thing. There's no memo, no special rule. Room 4 gets cleaned, stocked, and used like any other. We've had dozens of patients recover in there, go home, get better. But when you're in there during those quieter moments, post-code, post-sedation, when monitors slow down and you're just watching the numbers, you notice it, that quiet smell, like remembrance, and we all feel it. We call in chaplains more often than people think. The general public assumes we only use them for last rites or end-of-life care. But really, chaplains play a huge role in trauma hospitals, whether it's helping a mother process her son's overdose, sitting with a grieving father after a stillbirth, or being present in that strange in-between, when you don't know whether the patient will make it or not. They're not just priests, not always clergy. Most are trained in interfaith care, hospital certified, HIPAA compliant, trauma informed, and emotionally steady in ways even some doctors can't manage. They show up when we don't have the right words. That night started rough, back-to-back traumas. First was a code stroke brought in from a retirement center. The second was worse. A man in his late 60s, found down in his home. No signs of forced entry. Neighbor called it in after noticing he hadn't collected his mail in 2 days. EMS got him here with agonal breathing, GCS of 3, pupils sluggish, BP crashing. We worked him hard, fluids, dopamine, rapid intubation. But by the time he got to trauma room 3, we were just playing catch-up with what his body had already decided. We stabilized him just enough for ICU transfer, but no family, no DNR on file, no one to call. The social worker and charge nurse both tried running down leads, but he was alone. The last note in his chart was from a previous visit for chest pain. A brief ER eval 6 months back. No next of kin listed. No emergency contact. He was still unconscious, but we all knew what was coming. End-of-life discussions were inevitable. And in these cases that usually meant a chaplain. I was helping clean up the trauma bay when I saw a man walk in, early 60s maybe, neatly dressed, black sport coat, collar but not Roman, just simple understated. He carried a leather-bound pocket Bible and a small notepad, moved with calm, confident. I assumed he was the overnight chaplain. He didn't say much, just nodded at me, asked for the patient's name and whether he was conscious. I gave him a brief summary, unresponsive, suspected massive stroke, awaiting final neuro consult before likely extubation. The chaplain stepped quietly into room 3 and closed the curtain behind him. He stayed in there maybe 15-20 minutes. I peeked in once. He was seated at the man's bedside, holding his hand, eyes closed, head slightly bowed. No theatrics, just presence. I had other patients to attend to, but when I came back around to check on things again, the curtain was open, and the chaplain was gone. No sign-in, no name on the consult list, just gone. The man passed later that night. Brain death was confirmed. We kept him on the ventilator another hour while final paperwork was filed, and then he was formally pronounced around 3:30 a.m. The night was quiet after that. The next morning after shift report, I stopped by the spiritual care office. I just wanted to say thanks to whoever had come in. Even in that brief moment, it mattered, especially for someone dying alone. But when I asked, the daytime coordinator looked confused. "Last night," she asked, pulling up the on-call calendar. "Yeah, older white gentleman, black coat, neat silver hair, said he was the chaplain, sat with our trauma patient in room 3 for a while." She turned the screen toward me. The calendar was blank. The on-call slot was unfilled. Apparently, the regular overnight chaplain was out sick, and they hadn't been able to get a replacement in time. Nobody had been assigned. No one had answered a page. She even checked the logbook. No entries, no visitor badge issued to spiritual care that night. Thinking maybe someone just forgot to sign in, I asked if she could confirm who fit the description. She paused for a long moment. Then she said quietly, "That sounds like Chaplain Roland. He retired 3 years ago. Passed away last fall." I stood there, silent. I knew what I saw. I interacted with the man. I handed him the patient's chart. I heard his voice, calm, soft, present. I watched him sit beside a dying stranger and treat him with dignity. The coordinator turned back to her screen. And no, before you ask, he didn't have a twin. I left without pushing further. What was I supposed to do? File an incident report. Call security and say, "Hey, I saw a dead chaplain." Hospitals carry things, grief, memory, echoes of people who spent their last hours in these rooms. And maybe, just maybe, some leave something behind, or return when they're needed again. All I know is that man didn't die alone. Someone sat with him, held his hand, and if that someone wasn't on our payroll, then maybe some part of this job really does go beyond what we chart and scan and code. Hospitals aren't quiet places. Not really. Even at 3 a.m., when the hallways thin out and the chaos slows, there's always something: the hum of the IV pumps, the low beep of telemetry, a stretcher wheel squeaking down the corridor. You learn to block out the sound, but movement, that's harder to ignore. The service elevator near our trauma bay is old, built into the east wall of the ER corridor, across from room 11. We use it to move equipment, trauma overflow, the occasional ICU step-down patient, headed up for scans. Staff only, no public access. It runs from the basement storage to the 3rd floor, ICU, neuro and admin offices. There are 3 elevators in that section, but it's always that one, elevator C. Every night shift, sometime between 2 o'clock and 4 a.m., it opens by itself. No chime, no call light, just a soft click, then the doors slide open, always when passing the ER floor. Always when it stops directly across from room 11. Never when the elevator faces the linen alcove or the meds fridge on the opposite side. Always room 11. At first we thought it was a glitch. Older hardware, faulty sensor. We filed a report with engineering. They ran diagnostics during the day, couldn't replicate it. Replaced the door sensor. Still happened. Facilities brought in a third-party contractor to check for magnetic interference, panel faults, motion sensors. Anything that might explain a phantom call. Nothing. And it's not just opening while idle. This elevator opens mid-transit, when passing ER. That's not normal behavior. Elevators don't just interrupt their route to open doors on a floor. No one summoned. especially facing the same exact room every time. One night, I was documenting vitals after a respiratory distress case in room 9. I heard the soft whoosh behind me, turned, and there it was. Elevator seat, doors open, no one inside, hall empty. Room 11 across from it, lights dimmed, curtains drawn. The patient inside, stable post-syncopal episode, sleeping under light sedation. It wouldn't have stood out, except it happened again 2 hours later. Same sequence, no call, no code, no traffic on the floor, just open doors. Staring into room 11 like it was responding to something that wasn't logged. I mentioned it during shift report. Most of the newer nurses brushed it off. Glitch, faulty wire, no big deal. But the older staff, those who'd worked here long enough to remember before the new paint, before the last 2 remodels, they got quiet. One of them, Dana, leaned in and said, "Room 11 used to be Recess 2. Recess 2 was the overflow code room. This was before my time. Back when we only had one trauma bay and needed another crash room for mass casualty events or high acuity cardiac arrests." According to Dana, there were a series of bad cases in that room. One was a pediatric arrest that didn't make it. Another was a stabbing victim, pronounced at 3:11 a.m. after 3 rounds of EPI and unsuccessful defib. That patient, she said, was brought down via elevator seat. The room was renamed and restructured after the last ER expansion. New walls, new lights, a fresh start. But elevators don't forget. I didn't believe any of that until I started charting the times. I kept a small notepad on me. For 2 weeks, every time the elevator opened uncalled, I jotted the date, time, and who was in room 11. Pattern 1. Always between 2 o'clock. 4 a.m. Pattern 2. Only if a patient was currently in room 11. Never opened if the room was vacant. Pattern 3. Always opened when the elevator was passing, not stopped by staff. One night, we had a patient in room 11 who kept saying he saw someone waiting in the hallway. Not staff, not visitors, just waiting. When asked to describe the person, he said, "Not sure, just a shape, but I think they're here for me." The elevator opened twice that night. No call button pressed. No one exited. No one entered. He coded the next morning. Unwitnessed arrest at 4:12 a.m. We found him pulseless during routine rounding. We don't talk about room 11 in terms of ghosts or spirits. We're professionals. We talk about vital signs, neuro exams, drug compatibilities. But there are some things that aren't part of any protocol and still leave their mark on the routine. Facilities eventually disabled elevator C's panel access to the ER floor during night hours. But it didn't stop. It still opens, just without the chime. Quiet, persistent, like it's waiting for someone who hasn't made it to the gurney yet. Now whenever I walk that corridor at night, I glance toward room 11, and if elevator C opens, I just keep walking. Thank you so much for watching and being part of this growing community. Your support means the world to us, and it's what keeps these creepy, fascinating, and sometimes comforting stories alive. We'd love to hear from you. If you've experienced something eerie, unexplained, or deeply moving, feel free to share your own story in the comments below. You never know, your story might be the next one featured. And if you haven't already, don't forget to subscribe, like, and share to help keep the chills coming. We couldn't do this without you. See you in the next one.